Thyroid radiofrequency ablation is gaining momentum as a game-changing treatment option for thyroid nodules, but it also is raising tough questions in the surgical world. Can RFA really stand alongside surgery as a safe, effective treatment option for thyroid nodules and even certain cancers? And how do surgeons defend this newer approach to their peers who remain skeptical? Today on Save Your Thyroid with Jennifer Holcomb, we sit down with two leading surgeons at Baylor College of Medicine in Houston, Texas, Dr. Raymond Grogan and Dr. James Suliburk from Baylor St. Luke's Medical Center, who are pioneering thyroid ablation techniques in the United States. Thyroid ablation has been used for decades abroad, but it's just now gaining traction here in the U.S. Doctors Grogan and Suliburk run a high-volume thyroid, parathyroid, and adrenal center, offering innovative, minimally invasive therapies, including RFA, for carefully selected patients, including those with small papillary thyroid cancers. In this episode, we'll explore how to defend RFA to other surgeons and overcome skepticism, the evolving role of RFA in treating papillary thyroid cancer, or PTC, the ethical and practical challenges of clinical trials on RFA, and why randomized controlled trials aren't always feasible. Doctors Grogan and Suliburk share a deep commitment to patient-centered care and shared decision-making, pushing the boundaries of what's possible at a state-of-the-art academic medical center. If you want a clear-eyed look at the future of thyroid care and what's really happening behind the scenes in surgical innovation, this episode is for you. Let's get started. Welcome to the podcast, guys.
Thanks, Jen.
Yeah, thank you.
If you would take a moment, please, and introduce yourselves to the viewers, that would be fantastic.
Sure, I'll let Ray go first.
My name is Ray Grogan. I'm an endocrine surgeon, so meaning we specialize in thyroid, parathyroid, and adrenal surgery. I've been in practice since 2011, so a few years now. Mm-hmm. We do the entire spectrum of endocrine surgery, and we also are always looking at anything that's new and innovative to try to understand it better and understand if it's something that's feasible and something that's good for patients or not. That's kind of how we run the practice.
Mm-hmm. And I'm James Suliburk. I have been at Baylor since 2009 and practicing endocrine surgery. Actually started the endocrine surgery program at Baylor when I got here. It's kind of funny. I've been here. I'm now one of the more senior people in the department. I've been here so long. I make a joke that I can't really find a job anywhere else. But the reality is that Baylor is such a special place that we can do things that really are not possible anywhere else. And that's the reason why I've been here so long and enjoy all the innovation and all the ability to push the envelope that being a part of Baylor Medicine affords us.
Well, I certainly like to talk about pushing the envelope here on this podcast, so I'm really glad to have you here today. And let's start with talking about what is radiofrequency ablation. Now, a lot of the viewers who come to this podcast know what this is, but for any new viewers, let's give them kind of a brief overview of what this procedure is and how you're using it to treat thyroid nodules and small papillary thyroid cancers.
Sure. So what we do is under ultrasound guidance, we insert a needle into the targeted lesion. So anyone who's undergoing a thyroid or even a parathyroid intervention for that matter is going to start out this journey with a standardized neck ultrasound. And ultrasound is, our bread and butter modality for defining what's going on lesion-wise in the neck. It's painless. It's very accessible. One thing about it is that it is very operator-dependent, meaning that you do need to have an expert or experienced thyroid sonography group doing the ultrasound, especially when it comes to cancer-based diagnosis, where there's a lot more involved in the lymph node mapping than just a standard screening ultrasound. Ablation, we will use ultrasound, and we use a fancier ultrasound to use for the procedure. And we, under image guidance, guide a needle into the middle of the lesion, and then we connect that needle to an energy source. It heats up the end of the needle, and then that heat is transferred into the surrounding tissues. We then take that needle and use what's called a moving shot technique, meaning we will energize different portions of the tissue about a cc or a milliliter at a time. So for anybody who's watching, basically about the size of your pinky nail, about a little bit bigger than a pea, we sort of make a bunch of burns inside the lesion and ablate that tissue sort of 1 cc at a time. And depending on the size of the tissue, that can take a long time or not a lot of time. But one thing that's very nice about ultrasound is that it's very detailed, very precise, so we can see exactly where we're working down to the millimeter. And so that makes the procedure very safe in the hands of those who are experienced with this procedure.
I really appreciate you making that specific reference to the size of your pinky fingernail as you're treating. I don't think I've ever heard anyone describe it quite like that before. And I think that kind of makes it a little clearer to those of us who have, like myself, particularly large thyroid nodules that were treated with RFA, just how tedious it probably was for my physician going in there and treating every last corner of that thyroid nodule. So that was really interesting. Hey, just a quick break to share something I'm really excited about. My brand new website, saveyourthyroidwithjen.com. You can head there to subscribe to my mailing list and stay in the loop about new podcast episodes, videos, and updates in the world of thyroid nodule care. And I'm now offering something new, one-on-one patient navigation services. If you're feeling overwhelmed or unsure about your treatment options, I'm here to help. As a patient who's been through this myself and spent years learning from some of the world's leading experts in thyroid nodule treatment, I can help you make sense of your choices and feel more confident in your next steps. You can learn more about patient navigation and everything else I'm working on at saveyourthyroidwithjen.com. Now back to the conversation. Regarding the historical use of this technique across the globe, this has like a 20-year track record. Am I right? About 20 years overseas. Talk with us about why, with this long of a track record, is it just now gaining popularity just here in the last few years here in the US?
I think it's important to understand that ablation techniques have been done for decades, even before we were doing it in the thyroid overseas. So the track record for ablation in general, is decades long, essentially. There are several other organs where it's very routine to use these types of procedures. It started on the thyroid in Korea. Most people believe is where it really originated from in terms of treating the thyroid, and they've been doing it for quite a long time, as you mentioned. In terms of why it took so long to come to the United States, it's a good question. There's lots of different reasons for why that might have been the case, but in general, the thing is when American surgeons look to adopt things that have been looked at overseas, they want to make sure it's safe before they really adopt it. And I think that's really one of the biggest barriers. Number one is safety, improving safety. Mm-hmm. Due to the anatomy of the neck and the thyroid, there are some safety issues around using RFA or any other ablative technique in the thyroid. So I think that was probably one of the bigger barriers. There are some other things that probably kept it from coming to the US quite as quickly as well. But in my opinion, it's probably the biggest one.
Yeah, if you look at the economics of it from a device standpoint, bringing new technologies through the FDA and getting them approved for use is quite tedious. Right. And most of the medical device manufacturers are very large companies, multi-billion-dollar corporations, and they're very risk averse. And if they don't see the right economic analysis and there's too much risk in bringing it all the way through FDA, they're generally going to shy away from it. And so then what happens in the US market is that you end up using equipment that is not necessarily on label, that's not FDA approved. And of course, if you have an adverse event medical legally, that's really indefensible. And so, from a risk standpoint, certainly the US healthcare ecosystem and the economics associated with it do tend to limit innovation in some respects. And, I think the other thing that's kind of out there is we're now 5 years removed from the pandemic. But, prior to the pandemic, we had done a series of these using off-label equipment very successfully. But then once the pandemic hit, sort of everything really ground to a halt. Healthcare wise, and for a number of years. And so not just RFA kind of caught off guard, but a whole host of other technologies and surgical techniques are only just now starting to catch up to the innovation curve of where things were prior to the pandemic.
Wow. That's really interesting. I did not realize that you all were using RFA, in an off-label way before the pandemic. You want to talk about that for just a moment?
Well, that's part of what we do at Baylor, right? We are constantly looking to innovate. Heart surgery was essentially invented and developed by Dr. DeBakey at Baylor 50, 60, 70 years ago. And because we work in an academic medical center, because we work in an area where we have an environment that provides a very safe and patient-centered infrastructure for us to do prospective studies and for us to do prospective trials and to evaluate new technologies, we are able to be at the tip of the spear in the implementation, development, and use of the latest surgical technologies. And so at the time, as Dr. Grogan mentioned, ablation is very well proven for a number of other organs. And prior to the pandemic, we had one of our liver surgeons who was doing some very advanced ablation in the liver. And we piggybacked onto some of that infrastructure, and we're using at much lower power probes that originally had been designed for soft tissue indication for the liver. But because they had a soft tissue indication, we could move it over to the thyroid, although ergonomically it was not wieldy, right? Because these are probes that are 15 to 20 centimeters long, and we're trying to use that right here in the neck. And so it was a significant technical challenge. Nowadays, we have purpose-built probes specifically for the thyroid, and we like that because it's much better for the person performing the ablation, much better for the patient. It's just altogether a significant advance and leap forward.
Wow, that is really, really intriguing to hear you talk about that, because I've heard about how RFA was done in liver and kidney before, thyroid was kind of developed, the specific probes that you mentioned. And I can't imagine having to wield such a long probe in such a tiny area. For the viewers who are not familiar, the thyroid in the neck and all of the anatomy here is so small in comparison to the liver that, and there's also so many critical structures in the neck that physicians who do RFA or other ablative techniques have to be very aware of and very mindful of during the procedure. And so the safety element you mentioned is so important for the physicians as they're learning all of that. So we'll talk more about that in a moment. So perhaps that might be part of the common concerns or even skepticism in the surgical community. What would you say about that?
Yeah, I think for sure that goes back to what we were talking about a little bit ago and the safety profile of this. With the liver, there's a lot of room for that energy to spread around without damaging structures that are adjacent to the liver. With the thyroid, that's not the case. The thyroid is, as you already mentioned, sitting right up against several very important anatomic structures. And so you can't have the energy spreading out of the thyroid into these surrounding structures, which is really the biggest question about the safety regarding use of RFA, which now we know it is safe, of course, but at the time when you're talking about why did it not come to the U.S. sooner, these safety type issues related to the anatomy of the thyroid was probably one of the bigger barriers.
And so how do you approach the conversations with your surgical peers about this and really kind of convince them that this really is safe, especially when it's done properly and when you've got this really strong command of ultrasound and the anatomy in the neck?
Yeah, so that's an interesting thing. So once a surgeon is into practice, their skill set, a surgeon in practice, their skill set has been formed through years and maybe even a decade of really hard training. So residency is 5 to 7 years, plus another 1 or 2 years of fellowship, just under supervised training. And then once you get out into practice, I can remember my first 2 or 3 years into practice, you're still getting mentorship and help on challenging cases from your senior partners and colleagues. It's not until you've been into practice for, 2 or 3 years that you really start to hit your independent stride. And that's just because the human body is incredibly complex. Surgery is incredibly difficult. And so, you're looking at trying to get folks who've already spent 10 years acquiring a skill set to now go down another learning curve and bring these other techniques into their armamentarium. Now, fortunately, surgeons have good hands, right? And so, in most experienced thyroid surgeons, will already have a background in FNA and in thyroid ultrasound. So then we just have to put those two together. And, the learning curve for RFA is probably not quite as steep for a surgeon as it would be for somebody with a different background. And it's probably a surgeon's learning curve is probably a little bit higher than, for example, a radiologist's learning curve, because radiologists who are interventionalists are used to doing ultrasound guided procedures all day, every day.
Right.
But on the flip side of that is that an interventional radiologist doesn't have the overall understanding of the anatomy and physiology that a surgeon who specializes in thyroid, parathyroid surgery will have. So, for me, my surgical colleagues are the ideal people that I want to get involved in RFA. So then we talk about doing them, we talk about the great outcomes, we have honest discussions about any type of pain points around it, what makes the procedure arduous, how do you start out, when you're developing your practice and you're starting your cases, provide mentorship to whether it's telementoring or in-person mentoring. We have folks come down to train with us. Dr. Grogan and myself are both actively involved in training a future generation of endocrine surgeons, right? So we have folks who are, we're providing their training all the time. But when we talk to other professional surgeons who are out there in practice, it's okay, well, this is how you get started. Of course, there's an equipment barrier. You have to have the equipment, so link them up with the vendor so that they can get the equipment in, and then they can get some mentored practice, and then they can do their first cases. And we make sure to let them know, patient selection starting out is important. You don't want to start out with the most challenging case as your first, within your first 5 to 10 patients. But I think that, when we talk about learning surgeries, we know how many surgeries it takes to sort of go up the learning curve. And in RFA, we think that's somewhere between 5 and 10. We're going to do some work in the upcoming years to really define what that learning curve is. But, again, the challenge here is getting someone who's already in practice, who's already got a decade of well-honed skills to be hungry to continue that lifetime of learning and to continue to pick up something new and figure out how it's going to fit into their practice.
Right. And those are all very legitimate considerations to give, especially if you're in a private practice situation where you're really having to consider the finances behind all of this. I think one of the things that I've been told very frequently by physicians is that patient demand is actually a very important part of what's causing a lot of physicians to adopt this. Would you say that that's true in your experience, or were you so far ahead of the curve with the innovation aspect that were you not seeing patients that were asking for this that knew about this already at the point when you started doing it?
I think demand is from the patient side is important, particularly when a new technology is just developing, because as the technology develops in any particular country, the first patients that you're going to be using it for are going to be patients who are actively seeking it out, more or less. And so that demand certainly drives the beginning innovation. And it, of course, continues. I mean, if patients are coming to your clinic saying, hey, I want RFA, of course, it's going to make you more likely to try to adopt that as a physician, depending on your reimbursement models, too. Of course, that plays a role as well. But patient demand, for sure, is certainly part of what drives anything in healthcare, realistically.
Yeah, and RFA is really a kind of a poster child for patient-centered treatment of disease processes, right? We traditionally, and in fact, Dr. Grogan and I, we take out lots of thyroids. We do lots of thyroid surgery. That's what we do. But we also are just hyper-focused on patient-centered interventions. And, you can't talk to someone who's an experienced thyroidologist and without being open about, once someone's permanently hypothyroid, there's different changes that occur in the body. We know that thyroid cancer patients have significant drop-offs in their quality of life.
Right.
We don't understand exactly why, but we know that happens. And so the concept of patients wanting to have thyroid preserving interventions, it should not be novel to anyone who's an experienced thyroidologist. Where this really hits the sweet spot is that, we're able to do high quality interventions in a thyroid preservation manner to meet the medical goals of therapy or the surgical goals of therapy while meeting the patient-centered goals for quality of life. And that's where RFA or any other percutaneous thyroid preserving procedure really is hitting the sweet spot. And I think any experienced clinician wants to offer the best, most innovative treatment that they can in a patient-centered manner that's going to make everyone happy at the end of the day.
I love that concept of shared decision making, patient centered decision making, because I think that that is key to making sure that everyone is on the same page. I've had personal experiences, and several patients in our community online have also mentioned experiences where the doctor and the patient were on opposite sides, and they weren't really coming to a conclusion together on what was best for that patient. And I understand that there are cases where patients kind of have unrealistic expectations and that they need to kind of maybe shift a little bit. But for the majority of patients who just want to keep their thyroid intact and they are good candidates, this is where we can kind of meet in the middle and say, okay, we're going to do this. It's going to shrink your nodule down and it's going to keep your thyroid intact. And with that in mind, let's talk about papillary thyroid cancer, because in the last, I would say 2 to 3 years, we've started Save Your Thyroid in 2019. We've seen a huge uptick in the number of patients who are looking for RFA or other thermal ablation treatment of papillary thyroid cancer. So this is a hot topic in our community today. So let's start by, I would love to hear why you as surgeons are open to doing this, because a lot of physicians aren't. And then let's talk about the criteria for patient selection.
So I think the reason why surgeons that treat a lot of thyroid cancer are open to the idea of RFA, in my opinion, stems back to data that we have from Japan over the last decade or so, showing that small papillary thyroid cancers can be watched, meaning we don't even operate on them. We simply just watch them with repeat ultrasounds every 6 months to a year. And when you do that over a 10-year period of time, only about 10 to 12% of those patients are going to end up requiring surgery, because these nodules are they're cancers, I should say, are relatively indolent in the sense that they don't spread outside of the neck. They don't continue to grow. They just continue to kind of sit there and do nothing. So we have this clinical data from Japan showing that that is a safe thing to do for the smaller papillary thyroid cancers. Number two, we have autopsy data showing that about 10% of the people in the world have papillary thyroid cancer at the time that they die. Meaning, for example, in the United States, there's probably 30 million people in the US walking around with a papillary thyroid cancer.
Right.
The overwhelming majority of them don't even know it's there.
Right.
So because of some of these data that have been accumulated over the last decade or so, the idea of less treatment for papillary thyroid cancer has slowly percolated in the medical community. And we as surgeons that, in particular, that do thyroid cancer surgery, kind of on the forefront of understanding that literature, I would say. And so then comes along this idea of, well, there's a middle ground here. We can either take it out or we can sit and do nothing. But now we have this middle ground option where we can do a treatment for it. We can burn it, or however you want to call it, ablate it, and then watch it. And so it gives, in some ways, it almost is like a peace of mind for patients, I think.
Right.
It's like, well, I don't want to just sit and have a cancer sitting in my neck and do nothing about it, but I'm still trying to save my thyroid and save my thyroid function. Well, we have this middle ground option here, which is, well, we can actively do something for it and then watch it after that and see, how it goes. And so I think that's what kind of the decision making a lot of patients go through with this. The thing is with thyroid nodules, with thyroid cancers, there are oftentimes several options and treatment pathways that we can go down. Oftentimes there's 3 or 4 different routes that we can choose for any particular thyroid nodule or even a small papillary thyroid cancers. At that point, the decision making stops becoming a medical decision. It's no longer a medical decision when you have multiple medical options that are all okay from a medical perspective. It now becomes a personal choice option. So the conversation with the patient has to be, well, how do you want to live your life? What is most important to you? What is it you're trying to gain out of these different options? And when you apply that kind of thinking in the conversation with patients, it becomes clear that people are obviously very different. And some people want the
Right.
maximum possible approach. Get this thyroid away from me as fast as possible. Some people do not bring a knife anywhere near me for, for whatever. So that's how you end up with these different options, different choices, and patients are individuals and they should be allowed to have these different choices.
Yeah, and I think the other thing, especially if you're a patient if you look at small papillary thyroid cancers, say you're a patient who's starting this journey, you got a thyroid ultrasound, and next thing you know, they saw something, you need a biopsy, and now the biopsy's got the cancer word, it's got the C word. It's important to understand that you need to find an experienced team to take care of you.
Absolutely.
From a few years ago in the surgical literature, it was identified that 80% of thyroid surgery in the United States was being done by someone who did less than 5 thyroidectomies a year.
Wow.
And only 1% of the thyroid surgery in the United States, I'm sorry, only about 2% of the thyroid surgery in the United States was being done by a quote high volume experienced thyroid surgeon who does more than 25 total thyroidectomies a year. And so if you're a patient, the most common thyroid cancer, papillary thyroid cancer in America is a small stage 1, less than 1.5 centimeter papillary thyroid cancer. And so you want to first find an experienced team who knows how to manage it. Then second is you want to do your own research and identify, well, what are my options? And that experienced clinical team is going to help you through those options. Now, there are patients who have these small cancers, but who have significant lymph node metastases and multiple lymph node metastases, or they may have 1.5 centimeter lesion on the right, but then they have a few other nodules on the left, and actually they've got a multifocal papillary thyroid cancer and potentially bilateral lymph node involvement. So there's all these different things that are going on there. So step one is get an experienced clinical team, do your research, and then if you are a patient who has truly an isolated 1.5 centimeter or less papillary thyroid cancer, no lymph node involvement when we get an experienced high quality ultrasound, you're a candidate for ablation. Heck, you're actually a candidate for observation. If, like Dr. Grogan said, if you don't want anything done with your neck whatsoever, the data from Japan indicate you can be safely followed. In our experience, most of our patients that we treat, sort of we're, at the funnel, right? People want something done. And so I can certainly understand psychologically that it's pretty challenging to just sit there and go, yeah, I'm just sitting here with this cancer in my neck. I'm not doing anything about it.
Right.
And so RFA represents a very nice patient-centered modality to treat these people.
Mm-hmm.
The next step of this becomes follow-up. So it is tricky to follow these patients long-term. And so that means that, in patient-centered decision-making, the good candidate has to be willing to do the follow-up.
Right.
Okay? Because there's going to be some percentage of these patients who are going to progress despite having a very good RFA. They may turn up with lymph node metastases several years down the road. And at Baylor, we have some very innovative ways of following these patients from a molecular standpoint as they go through their survivorship. Again, all this boils down to is getting an experienced team who knows all the ins and outs of all the different options for treatment.
I want to touch base again on the point you made about high volume surgeons. That is absolutely staggering to think that. What percentage did you say again was high volume?
Only 2%.
So 98% of the thyroid surgery in the US is done by these low volume thyroid surgeons. That makes me think this must be why so many patients complain about having terrible outcomes after thyroid surgery, because so many of them are having thyroid removals from surgeons with a low volume of experience. And I would just like to drive that point home again, that if you're going to have thyroid surgery, please find a high volume surgeon. That is critically important. And then you mentioned just now molecular testing in your follow-up. I would like to maybe touch on that again, because in addition to these papillary thyroid cancers being a hot topic in the thyroid, Save Your Thyroid community, we're also seeing a lot of patients who have these indeterminate nodules, and they really need to pursue this molecular testing. So talk about that for just a moment.
Yes, there's something of a quirk with diagnosing thyroid cancer. About 80% of the time after we do a biopsy or fine needle aspirate, we're going to get an answer either positive or negative. Yes, cancer, no cancer, benign. But in about 20% of cases, when the pathologist looks at those cells under the slide, they're just not going to be able to determine if this is a cancer or not. And there's some technical reasons why that's the case. And so one of the tools that we have available to kind of circumvent that is to do molecular testing on FNA biopsies. The point of the molecular testing is to determine if there are risky mutations within those cells that we know give you a higher risk of having papillary thyroid cancer or follicular thyroid cancer. And so the molecular testing is an adjunct for indeterminate thyroid nodules to try to determine if they are benign or malignant. Molecular testing has matured significantly over the last decade. It's another technology that when it came around, people were very skeptical about it. In this case, it's not really about safety, but it's more about efficacy and whether or not it actually works. I think the data are clear that there are certainly cases where the molecular testing will show that something is benign when it was called indeterminate by the pathologist, in which case that does not necessarily need a surgery for. So that's kind of the synopsis of what we're doing with molecular testing on the biopsy side of things. That's different from what Dr. Suliburk was referring to in terms of follow-up after treatment for papillary thyroid cancer. Do you want to talk a little bit about that as well?
Yeah, so traditionally, thyroid cancer patients end up with total thyroidectomy plus or minus radioactive iodine ablation to zap every molecule of thyroid tissue in their body. And then the follow-up involves measurement of a protein called thyroglobulin, which is secreted by thyroid cells. And so if the patient has a recurrence of thyroid cancer, we can detect it by measuring thyroglobulin at a microscopic level. And what we're doing at Baylor is that now, and then the problem with that is that if there's, say you have your thyroid, and the most common conundrum that we face is somebody has a unilateral thyroid resection for a small cancer, but you still have the other side of the thyroid in there. You can't really measure thyroglobulin because it's really all the cancer detection is being overwhelmed by the normal thyroid tissue in there. So thyroglobulin is not a good biomarker. Clinicians are uncomfortable with this and have been for decades. It's uneasy when it's, quote, so easy to just take it all out. Now I can just measure a blood test. And so at Baylor, we are currently evaluating the utility of looking at circulating tumor DNA of the actual small cancer itself, or large cancer, for example, because we treat not just small cancers, we treat very advanced large cancers as well. But moving into the next step in the next direction of this is that we will be measuring and looking for, and we are measuring and looking for circulating tumor DNA. And what that allows us to do is that allows us to just look specifically for cancer cell recurrence in patients who have their normal native thyroid tissue still functioning and still doing well within them. And we're currently prospectively looking at that and employing that in our survivorship for thyroid cancer patients.
So
at the same time, we're also developing a next generation of molecular testing for preoperative diagnosis. So we're developing our own version of molecular tests off the FNA. Again, with the idea being, can we outperform the current generation of molecular tests? Can we keep more patients out of the operating room and spare them from getting unnecessary interventions on their thyroid?
Wow, so many cool things here I want to think about. So going back to what you were saying about the circulating tumor DNA, does that enable you to determine if a patient is having a recurrence before it's visible on ultrasound?
That's the theory. And again, we're looking to see whether that's really the case or not, but we are employing it. It's in full production, and that's the theory.
So circulating tumor DNA has been used in other cancers as well. It's not a new idea, but it's new in terms of actually being put into clinical practice. It's been in the research world for quite a while, but only recently, within the last few years, has there ever been a commercially viable test for circulating tumor DNA. I would say in the thyroid, it is still somewhat in the experimental level. We don't have a lot of good data to see how well this actually works yet, but theoretically, it should work quite well. And RFA on papillary thyroid cancers is the exact use case for why you would want circulating tumor DNA
Right.
for thyroid cancer.
Yeah, that is incredibly helpful if it is successful, as you're saying, because so many times when I talk with physicians about RFA for thyroid cancer, the follow-up is their biggest pain point, where they're concerned about, now that we've ablated this tumor, we really can't tell the difference between the fact that it's changed visually on ultrasound because of the ablation or because it's cancer. And so you just kind of have to be comfortable with being uncomfortable when you're following these patients. And then regarding molecular testing, is there any value in trying to rebiopsy and run molecular testing on these patients after they've had RFAs? Because my understanding is that that tissue, once it's dead in pathology or molecular test, is not really going to be much benefit there. Am I understanding that correctly?
That's correct. Is you're just biopsying the scar.
Right.
So those molecular tests or those FNAs have never been evaluated for their performance in that type of a lesion. That's not how the tests are originally designed, proven, and developed. There's really not any, it's a complete unknown. So to be honest, it's really a waste of time to try to do that molecular FNA test on a RFA ablated piece of tissue, because nobody knows the performance of the test in RFA ablated tissue. It could completely inappropriately reassure, or it could completely inappropriately call a recurrence. It's completely unknown what to do. That'd probably be a whole other podcast to
Right.
talk about, biopsies and the ins and outs of all that type of stuff. But I just simply say that that's a complete unknown either way, for or against.
Well, I think that this topic that you brought up about the circulating tumor DNA is definitely one I would love to talk with you again about in the future when you have more data to share about that, because that is very, very interesting to me. And I would love to follow up on that with you. I'd like to take a moment to thank the sponsor of this episode, Cambridge Interventional. Cambridge Interventional, a US-based company, has decades of experience in development, manufacturing, and sales of RFA and other medical devices. Radiofrequency ablation is a non-surgical, minimally invasive thermal ablation procedure used to treat various tumors, including thyroid nodules. If you have watched this channel before, you know that I personally underwent thyroid RFA treatment for a very large thyroid nodule and was able to save my thyroid and avoid surgery. If you'd like to learn more about Cambridge Interventional, please visit their website, cambridgeinterventional.com. A big thanks goes out to Cambridge Interventional for helping physicians to save thyroids and also for supporting this channel by sponsoring this episode. Now, back to the podcast. So let's circle back to, we were talking about papillary thyroid cancer that's treatable with RFA. What are the criteria? What size, what location, what exactly does a patient have to have? What qualifications do they have to meet in order to be treatable with RFA for papillary thyroid cancer?
So because it's still relatively new to be treating cancers with ablation, at least in the United States, the size criteria is somewhat variable, but it has to be a small papillary thyroid cancer for sure. I think most people in the US are having a cutoff around 1.5 centimeters at the most. This is in part to mimic the data from Japan on watchful waiting. The other thing with these things is they cannot be near any important anatomic structures, because what we want to be able to do is to apply energy not just to the middle of the tumor, but all the way around the periphery of the tumor as well. And so we can't have a tumor that's sitting right up against an important anatomic structure be treated with this technique, because you'll be putting those other structures at risk. So, those are two of the more important criteria: size and then location away from, in particular, the recurrent laryngeal nerve and the carotid artery, and the trachea as well. So mostly those two structures are what we're looking for that tumor to be away from.
And then the other item that's important to understand is that we much prefer that people have a single isolated lesion. They don't have any other high-risk lesions around. And of course, they can't have a neck full of lymph node metastasis. So we'll get very careful, very detailed lymph node mapping of their entire neck, and any nodes that may be enlarged or suspicious, we will biopsy, because if they have spread to the lateral neck, that does indicate a more advanced aggressive biology potentially.
Mhm.
And so then it's very important that we identify, is that something, if it's just a single isolated node, is that something the patient still wants to consider percutaneous intervention for, and really get into the ins and outs of what that's going to take in terms of surveillance, in terms of ongoing therapy. But we tend not to ablate patients who have lymph node involvement because that is a more advanced stage of disease.
Right.
And generally will require, more advanced aggressive treatment than simply an isolated solitary ablation of a lesion.
And what about lymph nodes after a thyroid surgery when a patient comes back with one lymph node recurrence? Are you treating those with RFA now?
Yes.
Very
So
good.
lymph nodes, so thyroid cancer recurrence is also a significant problem. And lymph nodes come in, they're either central neck, meaning in the middle, or they can be out here on the lateral neck. And depending on the location of those nodes, there's different risks involved in thermal ablation of them. And so, again, every patient is different, requires assessment by an experienced clinician. And then based on the location of the node, they potentially can be a candidate for a percutaneous intervention. And we have successfully treated patients with isolated lymph node recurrence or persistent disease. One more advanced thing we find is that in a patient who's already had a neck dissection, who's had a total thyroidectomy, and now they've got one node sitting there in an already operated field, that's actually an ideal situation for us to try to deploy a percutaneous intervention and spare that patient a reoperative, a 2 or 3 time reoperative neck surgery.
Amazing. Yeah. Those patients are done with surgery at that point. They just don't want to have any more surgery. So I have one more question about this topic before we're going to move on and talk about trials. But a common question I see from patients is they've had a molecular test that says that their nodule is benign or cancer. So when you compare a benign result from a biopsy versus a benign result from molecular tests, do you weigh those kind of equivalently when you're determining candidacy as well as with thyroid cancer?
Yeah, so to understand how to look at that, you have to understand what the accuracy of these two different tests are. And this is a conversation you have to have with the patient, and so that they can have an understanding of what this means, and what risks they're taking on with whatever decision they're making. So the bottom line here is even the pathologist reading benign, there's still a 2% error rate there.
Right.
So essentially, if a pathologist tells you the thyroid nodule is benign, 98% of the time it's going to be benign. But in around 1 to 2% of cases, you're still going to have a cancer there that they just weren't able to identify. With the molecular testing, the error rate is around 4%. So it depends on how you look at it. You could say, well, that's double. So is it as accurate? But then again, at the same time, it's only a 4% error rate, meaning 96 out of 100 times that's going to be benign. And so from my personal perspective, I tend to look at a benign molecular test as benign because there is nothing in medicine that is 100% guaranteed. There's nothing 100% certain. Even with our pathologist results, we still have some room for error.
Mm-hmm.
However, I do let the patient know and understand that there is a slightly higher risk that this could be a cancer, even though it's benign. So that's the conversation I have with patients. But majority of patients understand this. Obviously, majority of them are okay with going with the idea that, at least in my conversations, that a molecular test is nearly as good as a pathologist result. And the same applies for reading cancer as it does for reading benign. In fact, in some cases, depending on the mutation you find, there may be an instance where it's almost definitive that there's a cancer there, or there will at some point be a cancer. For example, for a BRAF mutation in a thyroid nodule, we would basically consider that to be an extremely high risk for cancer, if not just it is a cancer. So But in general, that's kind of how I look at this and talk to patients about it.
I think we might need to do another episode all about this because it's such a common topic that comes up in our community. So thank you for all of that explanation. It's very helpful. Now we're going to change gears and we're going to talk about randomized controlled trials, the research landscape on RFA. Now, Dr. Suliburk and I had this conversation before when we were planning this episode about how this is kind of hard to do in terms of RFA. So would you share that with the viewers, what we were discussing about how randomized controlled trials, first of all, what is a randomized controlled trial and how those are very rare or maybe even non-existent when it comes to thyroid surgery?
Yeah, so randomized control trials represents an experimental design study where patients are randomized to one treatment or another, and then we compare the outcomes down the road. Now, the drug trials are done with also placebo control, meaning patients are randomized to receive no drug or study drug, or they're randomized to receive a study drug plus standard of care, or they're randomized to receive placebo plus study drug. In surgery, there's no placebo. We know if you've had surgery or not. We can't do sham surgery. There has been sham surgery trials. There was a sham surgery trial done of knee arthroscopy by the VA health system 25 years ago. And that's kind of the last sham surgery trial I can think of that had been done in the United States. So today's modern world, we can't do sham surgery. It doesn't work that way. I can't subject somebody to anesthesia, and at the end of it, they'll know if I cut their neck or I didn't cut their neck.
Right.
Now, when we talk about trials in thyroid cancer, especially trials in early stage small papillary thyroid cancers, you have to follow patients out 5 to 10 years to see any kind of difference. And in fact, you are likely to have to follow patients even further out than that.
Wow.
And it's very difficult to follow somebody out for 5 years, let alone 10 years. The reason is because those patients are going to do well, okay, no matter what happens to them. And like Dr. Grogan said, in Japan, they've done this just as an observation. And we know that with nothing alone, these very early stage small cancers, those patients do well with absolutely no intervention, let alone trying to compare one intervention to another. So even if we were going to do it, we'd have to start right now. We wouldn't get any data back for 5 years at the earliest, and we would literally need thousands of patients to do that. And the reality is that would cost tens of millions of dollars, and nobody is really interested in funding that because at the end of the day, again, patients are going to do very well regardless of what we do. And so from an ethical standpoint, we can't do it. From a financial standpoint, we can't do it. And to be honest, from a research question standpoint, it's not a very interesting question. What we concentrate on is interventions that we know will control the oncologic process, and then how do we best optimize that patient's outcome and quality of life going down the line as we move forward into survivorship. And that's something that we can do by simply treating patients, making patient-shared decision-making decisions, and then following them with best quality, best practice care. And then we can turn around and see how those patients did compared to historical outcomes and make sure that we're providing optimal quality of life and make sure that our cancer recurrence rates or cancer-related complications remain very, very low.
So the data that we look at for patients who've had RFA is generally that observational data. It's not going to be the randomized type of data. How does this really shape our research in this field? Because I know that it's different, obviously, in the way that it's designed. How does that provide, what are the limitations there, and how is it shaping the research?
Well, I think that, for a long time now, the double-blind randomized controlled clinical trials have kind of been the end-all be-all of definitive answers, if there is such a thing as definitive answers in medicine. So anytime you don't rise to that level, there's always going to be questions as to whether or not what you're seeing in the data that you have, in observational data, is true or not. Is it just an association, or is there a causation there? And so you never have the gold standard answer is kind of the problem with, however, and this is, an old trope, but no one ever did a randomized controlled trial on parachutes because some things are very obvious, right?
Right.
So with papillary thyroid cancer, if we look at these studies observationally over a 5 to 10 year period of time, and we see that patients are not dying from their papillary thyroid cancer after an ablation, and we see that they're not having extra bouts of recurrence after an ablation from papillary thyroid cancer, in my opinion, it's perfectly reasonable to conclude that that's a good alternative to surgery or observation only. But you're always going to have people who will say, oh, it's not a randomized controlled trial, so you don't know the gold standard truths. And that's the conundrum you run into with a lot of things in medicine. Like papillary thyroid cancer is not, alone in this regard. There's a lot of things that we can't study in that rigorous manner in medicine.
I think the consensus here, though, is pretty not conclusive, but encouraging, considering that we have data from countries all over the globe that is very, very positive in terms of how patients do with RFA, whether they have benign or malignant disease. So thank you for all of that explanation. That's very, very interesting. Now I want to talk about the advancements that you're having at Baylor. We've already talked about some of them, but what are the advancements that you've seen, and where do you think we're headed in terms of non-surgical thyroid care?
Yeah, so, again, working at Baylor, we have an amazing environment here in the Texas Medical Center where we can push the envelope on a day in, day out basis. We've made the leap. If you look at things over the last, where have we come over the last, 4 years? Well, we've made the leap to doing ablations for indeterminate thyroid nodules, right? We've made the leap now. And so that was sort of step one. And then step two is, okay, we've made the leap and now we're going to do early stage thyroid cancers. And when we talk about neoplasia, right? So now we're doing, 1 to 1.5 centimeter thyroid cancers. And, even somebody has an 8 millimeter one, right? Small enough we can target it, we'll get it. I think that gray zone between 1.5 and 2 centimeters sort of is an area that we need to sort of very carefully evaluate whether those patients are going to be candidates, because if you show up and you've got a 1.6 or 1.7 centimeter cancer, are you all of a sudden looking at losing your thyroid, right? It's only 1 or 2 millimeters difference, and maybe that's just the measurement of the calipers on the ultrasound. So I think that certainly is an interesting area. At Southwestern, one of our endocrinology colleagues just published a very interesting limited series of Graves patients who were treated successfully with ablation. And so certainly Graves' disease remains a very challenging, very vexing disease process for patients. And we want to identify, is there a role for percutaneous ablative therapies in Graves' disease? And then it's well proven for isolated solitary toxic nodules that ablation is a very good modality for these patients. And I think, it's pretty well proven that for lymph node mets, isolated lymph node recurrences or metastasis ablation is very good. So I think Graves, larger cancers, and then from the technology side of things, literally every 3 to 6 months, somebody is coming up with a new innovative set of equipment or probes or devices, or even ultrasound imaging guidance, right? With the AI revolution, we have the ability to compute these images in real time and get 3D reconstructions and get more precise than ever before in real time as we're targeting these lesions. So I think those are all the really exciting things that we look forward to in percutaneous interventions of the thyroid. While in the background, the current things that we're doing, follow up with circulating tumor DNA, advanced molecular testing, developing novel tests, these all sort of will help to augment things. Dr. Grogan is, developing a novel test for parathyroid stuff. So possibly in the future, we're going to be treating single parathyroid adenomas percutaneously because we can identify them so rapidly with Dr. Grogan's innovative tests. These are really exciting times to be in the field.
Definitely. Wow. I've really just felt like my mind has opened up even more in this conversation. Any final thoughts you want to share before we close out today?
Yeah, I think that, in general, for high volume surgeons and for people who treat papillary thyroid cancer and benign thyroid nodules, ablation is here to stay. I don't think it's going anywhere. I think it has been accepted in the community now, in the medical community. And where we're at with it now is essentially trying to figure out how far can we take it. And these are the questions that are going to start arising, as Dr. Suliburk just alluded to. So it's an exciting time. I think it's a great modality. It's a great thing to offer patients. I think all patients should have the chance to at least have a discussion about whether or not they're eligible for these things at the minimum. And as more physicians adopt these techniques, the stronger that's going to become.
Yeah, and I think that, if the one message we could just hammer home really is if you're a thyroid patient with recently diagnosed disease, or you're sort of starting this journey, or maybe you're 6 or 3 months in and you're so confused you don't know what to do, number one is just find an experienced clinical team. There are tons of people who dabble in the field, but there is a very limited set of really experienced providers. One thing that's great about your community, Jen, is that certainly your community is able to guide people towards experienced providers. And then there's a variety of other society-based things, whether it's the American Thyroid Association, American Association of Endocrine Surgeons, the Head and Neck Society, but there are physician finders amongst these professional societies of experienced clinicians. But I can't emphasize enough how important your peer support community is, Jen, in helping these patients to navigate those unknown waters of finding an experienced clinical team.
Well, thank you. That means a lot to me. It's been 6 years since we created the community, and I learn something new every day from physicians like you and from my patients. And so I'm just really grateful for how far we've come in 6 years, and how far the physician community has as well. I'm so excited to hear what you two are doing. How can patients connect with you too if they want to become patients of yours?
Yeah, just find us on the internet. We're at the Thyroid and Parathyroid Center at Baylor Medicine in Houston, Texas. It's pretty straightforward to Google us, and you can send in an online informational form or call the office to register and do our general intake to be seen. We do provide, telehealth consultations for all patients, especially in the state of Texas. If you're outside the state of Texas, it's a little bit more nuanced, and that just basically has to do with state regulatory laws on medical licensure and treatment. But we can certainly have education sessions with patients that live outside the state of Texas. But if you have community members in the state of Texas, it's very straightforward. Just register with us online, and you can come in person or telehealth, and just find us at the Thyroid and Parathyroid Center at Baylor Medicine in Houston, Texas, right?
Yeah, I agree. We are able to treat people from outside Texas too. Like Dr. Suliburk said, there are some nuances to that, but it's completely doable.
It's not uncommon for our patients to travel to find the physician that's right for them. So I'm glad that both of those options exist. So thank you both so much for your time today. This has been a wonderful conversation.
Thank you.
Thank you.
That wraps up today's episode. If you found this valuable, please like, subscribe, and share it with someone who might benefit. You can find links to everything we discussed in the show notes below. Find a physician, discover treatment options, and join our patient community at saveyourthyroid.org. To stay up to date on new episodes, resources, and expert insights, be sure to subscribe to my mailing list at saveyourthyroidwithjen.com. It's the best way to stay connected and informed. There, you can also find all podcast episodes and book a 1-hour patient navigation consult for personalized guidance on your next steps. As always, please remember this podcast is for informational purposes only and is not a substitute for professional medical advice. No endorsement is given or implied for any specific product, treatment, or physician mentioned. As always, consult with a qualified healthcare professional for your individual needs. Thanks for listening, and I'll see you next time.